In the 1950s, a doctor could arrive at a psychiatric hospital with a small metal instrument, a mallet, and a plan to operate on several patients in one day. The procedure was called a transorbital lobotomy. Its supporters described it as quick, modern, and practical. Its critics saw something very different, a dangerous shortcut being used on people who often had little power to refuse. Walter Freeman helped turn the lobotomy into a national campaign. He traveled between hospitals, promoted the technique to psychiatrists, and presented speed as part of its appeal. Some accounts say he performed as many as 25 procedures in a day. The exact number is difficult to verify for every claimed session, but the larger fact is not really in doubt. Freeman treated psychosurgery as something that could be brought into ordinary psychiatric hospitals and repeated on a large scale. That is the unsettling part of this story. The lobotomy did not begin as a joke, a horror story, or an obviously reckless experiment. It arrived during a period when doctors were facing overcrowded hospitals, limited treatments, exhausted staff, and families desperate for an answer. The promise was simple: change the brain, change the behavior, and perhaps return a difficult patient to a more manageable life. But the results were never that simple. To understand why the lobotomy spread, we have to go back to the hospitals it was supposed to help. During the 19th century, reformers promoted a new idea called moral treatment. Psychiatric hospitals were meant to be orderly, calm, and humane. Architecture became part of the theory. Long corridors, large windows, gardens, fresh air, and separate wards were supposed to create an environment where patients could recover. The design became associated with the Kirkbride plan, named after psychiatrist Thomas Kirkbride. The buildings were often impressive. From the outside, they looked like expressions of confidence in science and public care. But architecture could not solve unlimited demand. As the decades passed, many hospitals became overcrowded. A building designed for hundreds might hold far more. Staff were responsible for patients with very different needs, from severe psychosis to epilepsy, dementia, developmental disabilities, addiction, and people who had nowhere else to live. The ideal of calm treatment began to collide with the reality of institutional scale. Doctors tried different methods. Some used hydrotherapy, including prolonged baths, cold water, or wet sheet wrappings. Other treatments involved restraint, sedation, or early forms of electroconvulsive therapy. These practices were not all identical, and some were used with the belief that they could reduce distress or dangerous behavior. But the medical knowledge of the period was limited, and consent standards were not what patients would expect today. The hospital often had the final word. The question was not always, does this person understand and agree? It was often, what can we do to control the symptoms? That difference created the environment in which psychosurgery could flourish. In the 1930s, Portuguese neurologist António Egas Moniz developed a surgical procedure intended to disrupt connections in the frontal lobes. It became known as a prefrontal leucotomy, later more commonly called a lobotomy. The operation was invasive, difficult, and usually performed in a surgical setting. Walter Jackson Freeman was not a neurosurgeon, but he was a neurologist and psychiatrist with enormous confidence in the idea. Alongside neurosurgeon James Watts, he helped introduce the procedure in the United States. Freeman believed the technique could be simplified. Instead of a major operation through the skull, he promoted a transorbital approach through the eye socket. The instrument used by Freeman resembled an ice pick, which is why that image became permanently connected to the procedure. The nickname is memorable, but it can also hide the real history. The important issue was not the shape of the instrument. It was the decision to use a destructive brain operation as a treatment for people whose behavior was considered difficult, disruptive, or incurable. Freeman did not usually work alone at first, and the procedure was not simply performed in a kitchen with no medical preparation. But he did promote a method designed to be faster, cheaper, and easier to carry out in psychiatric hospitals that did not have a full neurosurgical theater. The procedure often involved electroconvulsive treatment to make the patient unconscious, followed by the use of the orbitoclast and a mallet. That description is enough to understand the seriousness of the intervention. We do not need graphic detail to see the ethical problem. A person's personality, emotional range, initiative, and ability to function could change permanently. Sometimes families reported improvement. Some patients became calmer or easier to manage. But calmer did not necessarily mean healthier. A patient might lose agitation and also lose motivation, spontaneity, memory, or independence. The same behavior that made a patient difficult for an institution could disappear because much of the person's ability to respond had disappeared with it. Freeman became one of the procedure's most energetic promoters. He traveled across the country in what became known as the lobotomobile, demonstrating the technique and encouraging hospitals to adopt it. At Athens State Hospital in Ohio, staff physicians observed Freeman perform a series of lobotomies in the 1950s. One of those physicians was Wolfhard Baumgartel, whose later oral history helped preserve what the experience looked like from inside the hospital. The Athens records also matter because they show that this was not only a story told by Freeman himself. Hospital superintendents and staff created their own documentation of the procedures. That evidence helps us separate the colorful legend from the historical record. Freeman's national total is commonly placed at around 2,500 transorbital lobotomies in 23 states, according to historical accounts. Other estimates of his total work differ, depending on what procedures are counted. The exact numbers matter, but they are not the whole story. Every number was a person who had a family, a history, and a future that could be changed in a few minutes. The central ethical problem was not simply that lobotomies sometimes failed. It was that the risks were difficult to measure, the benefits were often described broadly, and many patients could not give meaningful consent. Some were children or young adults. Some were institutionalized for years. Some were treated because they were severely ill. Others were targeted because their behavior was disruptive, or because the hospital had run out of alternatives. The same operation could be presented as a last resort in one case and as a convenient solution in another. If you're interested in the evidence behind these forgotten medical stories, subscribe now. This series is not built around ghost stories or fake shock. It follows the records, the people, and the decisions that institutions once tried to leave in the past. And leave a comment. Would you have considered a treatment ethical if the patient became easier to manage but lost part of their personality? The lobotomy era also overlapped with another movement that treated human lives as problems to be managed by the state: eugenics. Eugenics claimed that society could be improved by encouraging reproduction among people considered desirable and preventing it among people labeled unfit. In practice, the labels were shaped by racism, class prejudice, disability discrimination, and weak medical standards. Virginia passed a sterilization law in 1924. The law allowed the state to authorize compulsory sterilization of people classified as mentally ill or intellectually disabled. The Supreme Court upheld Virginia's law in Buck v. Bell in 1927. The case involved Carrie Buck, a young woman whom the state described as mentally defective. Justice Oliver Wendell Holmes Jr. wrote the majority opinion supporting the law. His language became one of the most notorious statements in American legal history. but the larger damage was institutional. The court gave constitutional approval to a system that removed reproductive rights from people judged unfit by the state.
More than 7,000 people were sterilized under Virginia's program, though published totals vary depending on the period and records counted. The safest description is that the number was above 7,000, not that every historical source uses the same figure. Sterilization was not the same as lobotomy. They were different procedures with different purposes. But they shared a dangerous assumption that authorities could improve society by making permanent decisions about the bodies and futures of people with limited power to object. Psychiatric hospitals became part of that system because diagnosis could influence who was confined, who was sterilized, and who was considered capable of making decisions. This is why the history cannot be reduced to one eccentric doctor with an unusual instrument. Freeman mattered, but he worked inside a culture that rewarded confidence, speed, and control. The hospitals were overcrowded, families wanted answers, governments wanted cheaper institutions, doctors wanted treatments that appeared to work quickly. The people receiving those treatments were often the least powerful people in the room. By the early 1950s, the weaknesses of the lobotomy were becoming harder to ignore. Complications included seizures, bleeding, infection, changes in personality, cognitive impairment, and loss of independence. Some patients could no longer return to the lives their families had hoped to recover. The treatment's reputation also began to change as alternatives appeared. In 1954, Chlorpromazine, marketed in the United States as Thorazine, entered psychiatric practice. It was not a miracle drug, and it had serious side effects of its own, but it offered hospitals a new way to reduce severe psychotic symptoms without surgically destroying brain tissue. Drug treatment, changing medical standards, civil rights activism, and growing criticism of institutional care gradually weakened the authority of the lobotomy. Freeman continued defending his work for years. In 1967, after performing a lobotomy on a former patient who had already undergone the procedure twice, he was barred from operating after the patient died from a brain hemorrhage. Freeman died in 1972. The procedure did not disappear overnight. Its consequences remained in families, medical records, long-term care facilities, and the memories of patients who had survived it. That word, survived, needs care. A person could survive the operation physically and still lose the ability to work, communicate, make decisions, or feel like the same person. A family could be told that the treatment had worked because the patient was quieter, even when the patient had become less present in their own life. This is where the phrase medical assembly line becomes more than a metaphor. The assembly line did not produce identical results. It produced decisions at speed, often under pressure, using people as the material of an experiment that institutions wanted to call treatment. The strongest conclusion is not that every psychiatric treatment from this period was useless, nor is it that every doctor involved was acting with cruelty. The evidence is more uncomfortable. Many physicians believed they were helping. Many families had run out of options. Many hospitals were facing conditions that modern systems would recognize as unacceptable. But good intentions did not erase the absence of informed consent. A desperate situation did not make a permanent brain operation safe, and a calmer patient was not automatically a healthier patient. The lobotomy era shows what can happen when a medical system values manageability more than autonomy. It also shows why historical records matter. Hospital reports, oral histories, court decisions, and family testimony allow us to compare the promise with the outcome. The promise was recovery. The outcome could be silence. The promise was efficiency. The outcome could be a lifetime of dependence. The promise was modern science. The outcome could be a permanent change made before the science was ready. Today, psychosurgery still exists in far more limited and carefully regulated forms for specific severe conditions. Modern procedures, Ethical review, consent requirements, and clinical evidence are not the same as the mid-century lobotomy campaign. That difference matters. The lesson is not that every intervention on the brain is immoral. The lesson is that medicine must be judged by evidence, consent, safeguards, and the real lives of patients, not only by the confidence of the people promoting it. The lobotomy became famous because of the instrument, the mallet, the traveling demonstrations, and the extraordinary speed. But the deeper story is about a system that was willing to call loss a cure if the loss made a person easier to control. So what should we remember? Not simply that Walter Freeman was controversial. We should remember the patients whose names are harder to find than his. We should remember the families who were promised improvement. We should remember the staff who saw the results up close. And we should remember that medical progress without patient power can become another form of control. If this episode made you think differently about the word treatment, tap like, subscribe for episode 3, and leave one comment. When a medical procedure changes a person's behavior but also changes who they are, what should count as success? The history of the lobotomy is not frightening because it belongs to a distant world. It is frightening because the people who performed it often believed they were moving medicine forward. And for a time, the hospitals, the courts, the press, and the public believed them.